So moving on to talking about drowning. This is the process of experiencing respiratory impairment from submersion or immersion in a liquid, obviously usually water. And so some risk factors here: alcohol consumption, particularly for teenagers, pre-existing seizure disorders, geriatric patients with cardiovascular diseases, and unsupervised access to water, usually with small children. So spinal injuries in a submersion incident, this could be complicated from this if the submersion has resulted from a diving mishap or a long fall, if the patient is unconscious, or if the patient complains of weakness, paralysis, or numbness. All of these are concerns that we would need to stabilize the spine, and we would do that in the water. And so I will try to post a video of backboarding a patient in the water so you can kind of see that. Most backboards will float, so you just need adequate number of personnel, whether you're in a pool or the lake or whatever it is, to be able to put the patient right on the backboard. If this is a water rescue, then you want to keep this in mind. It is reach, throw, row, and only then go, which means you don't want to put yourself in a situation where if you are in the water that the patient is grabbing onto you and potentially injuring you, pushing you down underneath the water, which is what will happen if you go out and swim to them. So make sure that you do not do that unless you're trained and experienced with those proper techniques. As far as resuscitation efforts, usually with drownings, especially cold water drownings, you have a higher chance of successing, higher chance of success with resuscitating the patient. And so just like when we were talking about the hypothermia, it's the same for cold water drownings. You have a really high chance of getting them back up because that cold water has kind of preserved the body and protecting the vital organs. So really want to give them some time, even if it's an hour or two that you're working the arrest. The diving reflex can cause immediate bradycardia. So that's basically you're submerged into water. Like when you dive into cold water, then your heart rate begins to slow down. So you'll see some test questions that ask about that as well. Looking at descent emergencies, these are caused by a sudden increase in pressure as the person dives deeper into the water. The pain forces the diver to return to the surface to try to equalize the pressure, and then the problem will generally clear up by itself. But divers with continued pain, especially ears, should be transported to the hospital. Injuries at the bottom for scuba divers, these rarely occur, but these can be caused by faulty connections in diving gear. So inadequate mixing of oxygen and carbon dioxide in the air that the diver is breathing, and accidental feeding of poisonous carbon monoxide into the breathing apparatus. And this can cause drowning or rapid ascent, meaning they're going to go up to the surface, but they're going too quickly, and it could potentially not allow for the pressure to equal out. With ascent emergencies, this usually requires aggressive resuscitation. An air embolism is the most dangerous and most common scuba diving emergency, which is where a bubble happens in the blood vessel. And so, like I said, when someone is trying to go up to the surface, if they do so too quickly, then this is where this can occur. So the air pressure in the lungs stays at a high level and the pressure in the chest decreases, and it's a bad combination. So a couple of things to consider here: you have decompression sickness, which can be called the bends, where bubbles of gas, especially nitrogen, can obstruct the blood vessels. Conditions that can cause the bends would be too rapid an ascent from a dive, or too long of a dive at too deep of a depth, or repeated dives within a short period. Another thing as far as the pressure changes would be like too low and then too high, meaning that you've been scuba diving and then you get in an airplane. And so it's really recommended that if you've been diving, that you don't go into an airplane or helicopter within a 24-hour period, again, just to allow your body to get to that equilibrium. You may find it difficult to distinguish between an air embolism and decompression sickness. The air embolism usually occurs right as they are returning to the surface, whereas decompression sickness may not come for a couple of hours. So that's kind of a red flag and something for you to consider there. The treatment for same is for both is the same. If they are in cardiac arrest, then it's going to be basic life support as far as CPR, and then eventually, if they are not in cardiac arrest or if they're resuscitated, they need recompression in a hyperbaric chamber. So you want to make sure that you are aware of the hyperbaric chambers available in your area. So like one is like here in Smithfield, it's over at our wound clinic. And so they usually don't do emergency cases, but if it was happening during the daytime while they were open, it's possible they could. But there's also hyperbaric chambers generally at our major hospitals, especially like Big Duke and UNC, where they do a lot of care like this. They have the hyperbaric chambers. So looking at scene safety, making sure that you have gloves and eye protection. Never attempt a water rescue without the proper training and equipment. Call for any additional resources that you need early. Consider trauma and spinal immobilization. Again, I'll post that video for you to be able to see the patient, how they are able to put a patient on a backboard in the water. Be suspicious of drug or alcohol use, especially if this is like a teenager and you're concerned that that could be part of the influencing factors. Looking at airway and breathing, you want to open the airway and assess the breathing in unresponsive patients. You want to consider spinal trauma and take the appropriate actions. Suction if the patient has vomited, provide ventilations or high flow oxygen, and auscultate and monitor the breath sounds. Looking at circulation, if they have no pulse, then of course begin CPR. If the mechanism of injury suggests trauma, then we do want to assess bleeding and treat appropriately. Looking at your transport decision, you want to always transport near drowning patients to the hospital. And that's the difference, is that if they are resuscitated from this, then it is a near drowning. If they actually die, then that is a drowning. Also, inhalation of any amount of fluid can lead to delayed complications like aspiration pneumonia and things like that. Decompression sickness and air embolism need to be treated in that recompression hyperbaric chamber, like we said. Looking at the history taking, you can get your sample history, determine the depth of the dive, the length of time that patient was underwater, the time of the onset of symptoms, and also any previous diving activity. So that's important to know. Are they an experienced diver? Was this their first dive? That type of thing. Doing your secondary assessment, you want to do your physical exam, listening to lung sounds, looking for hidden life threats, trauma indicating the bends or air embolism, and also any signs of hypothermia. You want to assess for peripheral pulses, skin color and discoloration, itching, pain, and any numbness or tingling. We want to check all of our vital signs, pulse rate, quality, rhythm, respiratory rate, rhythm, quality, listening to lung sounds, pupillary size and reactivity. Remember that your oxygen saturation readings may be inaccurate, particularly if the patient has been in cold water. That hypothermia can cause an issue. When we're reassessing, we're trying to repeat the primary assessment. Drowning patients may deteriorate rapidly due to pulmonary injury, fluid shifts in the body, cerebral hypoxia, hypothermia. Pneumothorax, air embolism, and decompression sickness patients may also decompensate quickly. We want to make sure that we're documenting the circumstances of the drowning and the extrication, whether the patient got themselves out, someone got them out before we got there, we got them out, that type of thing. An estimated time that they were submerged, the temperature and the clarity of the water. Also, was it salt water, fresh water, pool water? Possible spinal injury. If they have any dive logs or dive computers, we can bring that as well, and any dive equipment. So if they did have a scuba gear, tank, and that type of thing, so that it can be examined. We want to immobilize and protect the patient's spine if a fall or diving injury is possible. If they're not breathing, try to remove any secretions or vomit from the airway. We can assist ventilations with a BVM or a pocket mask, provide chest compressions, and use the AED if they are pulseless. And again, treating for hypothermia. So that means we want to dry them off, remove any wet clothing, place warm blankets on them, that type of thing to help maintain the body temperature. For air embolism or decompression sickness in a conscious patient, remove them from the water. Try to keep them calm. Administer oxygen. Consider the possibility of pneumothorax and monitor the breath sounds, and then provide prompt transport. Looking at some other water hazards, we want to pay close attention to the body temperature, again, especially if they were rescued from cold water. Thinking about breath-holding syncope, so a person swimming in shallow water that may experience a sudden loss of consciousness that's caused by a decreased stimulus for breathing. treatment here would be the same as it would be for a drowning patient. As far as prevention, it is our job to try to educate the public on some appropriate precautions that could help prevent some of these. So pools should be surrounded by a fence. The most common problem for child drownings is simply a lack of adult supervision. And then half of all teenage and adult drownings are associated with the use of alcohol. So we want to discourage alcohol when around water, and also making sure that people are never swimming alone. Thinking about high altitudes, so dyspareunism injuries caused by a difference between the surrounding atmospheric pressure and the total gas pressure inside of the body, that could cause like altitude illness, so diminished oxygen in the air at high altitudes. So this affects the central nervous system as well as the pulmonary system. So thinking about, again, not having the time to acclimate to the air, like up a mountain, if you're hiking, that type of thing. That would lead to like acute mountain sickness, where you have diminished oxygen in the blood caused by ascending too high too fast or not being acclimated to those high altitudes. These are a few other high altitude sicknesses. So high altitude pulmonary edema, where fluid collects in the lungs, hindering the passage of oxygen into the bloodstream. High altitude cerebral edema, where this can accompany this, and so cerebral edema, it's happening actually inside of the brain, and this could become life-threatening pretty quickly as well. If it's inside of the lungs and it's beginning to sound like pulmonary edema, then of course we have the option for CPAP. For the cerebral edema, there's not much that we can do in the field, but rapid transport would definitely be indicated. Looking at lightning strikes, there's a lot of targets of direct lightning strikes, like people that are engaged in outdoor activities, so boaters, swimmers, golfers, anyone in a large open area. Many individuals are indirectly struck when they're standing near an object that has been struck by lightning, like a tree, because it does transfer that and it conducts that energy out, and the person could be injured there. The cardiovascular and nervous systems are most commonly injured with lightning strikes, so respiratory or cardiac arrest is the most common cause of lightning-related deaths. And so lightning injuries could be mild, moderate, or severe. We do want to use reverse triage, and so if you've done all your NIMS or you've been looking at patient triage, then you know that we have the classification system of green, yellow, red, and black. And black would be anyone who's in cardiac arrest, and so we would treat the red, the yellow, the green first, but we actually use the reverse triage with lightning strike, meaning that if you have someone who is in cardiac arrest because of lightning strike, then you go to them first, because the quicker that you get there, the quicker you have the ability to potentially reverse that with the use of the AED. So reverse triage, you'll see that again. You need to know what that means as far as treatment for lightning strikes. Now, spider bites. Spiders are numerous and widespread in the United States. Only the female black widow spider and the brown recluse spider deliver serious or life-threatening bites. The black widow spider, the female, is a fairly large, measuring approximately 2 inches across. Usually she is black with a distinctive bright red-orange marking in the shape of an hourglass on her abdomen. They prefer dry, dim places. The bite might sometimes be overlooked. Now, most bites will cause localized pain and symptoms, including agonizing muscle spasms. And the main danger here is that the venom is neurotoxic. And so you'll see a test question that asks about that, but that is a neurotoxin. Generally, these symptoms will subside over 48 hours. Emergency treatment consists simply of just BLS care. If the patient is in respiratory distress, oxygen administration, rapid transport, bringing the spider or a photo of it to the hospital if possible. If you suspect that it is a black widow, then definitely we want to let them know that, so they can see if they have the antivenom, or if they don't, then can they get it. Looking at brown recluse spiders, they are a dull brown color and about 1 inch long with a violin-shaped mark on the back. They live mostly in the southern and central parts of the country. They tend to live in very dark areas. This venom is cytotoxic, so it causes severe local tissue damage. Typically, the bite is not painful at first, but it becomes so within a few hours. The area becomes swollen and tender, developing a pale, mottled, and cyanotic center. All right, so Hymenopterous things like bees, wasps, yellow jackets, and ants, they are painful but not a medical emergency unless the patient is having an allergic reaction. And so, of course, then we know what to do with that with anaphylaxis. The way that we can remove that stinger, as we talked about again in the allergic reaction or immunologic chapter, was to remove the stinger and venom sac using a firm edged item like a credit card to scrape the stinger and sac off of the skin, not against the grain. Looking at snake bites, of the approximately 115 different species of snakes in the United States, only 19 are venomous. Rattlesnakes, copperheads, cottonmouths, water moccasins, and coral snakes are some of these that we might come into contact with here in this area. I'm not going to spend a lot of time on this slide because it gives me the heebie-jeebies. Snakes usually do not bite unless they are provoked, angered, or accidentally injured. So help protect yourself from getting bitten by using extreme caution and wearing the appropriate PPE. The classic appearance of the poisonous snake bite is 2 small puncture wounds with discoloration, swelling, and pain. Now, pit vipers like rattlesnakes, copperheads, and cottonmouths, they have triangular-shaped flat heads. Small pits that contain poison are located just behind each nostril and in the front of each eye. So you can see how that venom is distributed through the bite. Rattlesnakes are the most common form of the pit viper. There are many patterns of color, and they usually have a diamond pattern. They can grow to be up to about 6 feet or longer. Copperheads are usually 2 to 3 feet long, and they have a red copper color crossed with brown and red bands. Their bites are almost never fatal, but the venom can cause significant damage to tissues in the extremities. Cottonmouths are olive or brown with black cross bands and a yellow undersurface. Water snakes with aggressive behavior and tissue destruction can be severe. So signs of envenomation include severe burning and pain at the site of the injury, and then swelling and bluish discoloration. If the patient has no local signs an hour after being bitten, then you can assume that an envenomation did not take place. Coral snakes are a small reptile with a series of bright red, yellow, and black bands completely encircling the body. They live in the southernmost states, and they inject the venom with its teeth and tiny fangs with a chewing motion, leaving puncture wounds. And so usually they bite a victim on the finger or the toe because they really can't open their mouths too wide. But coral snake venom is a powerful toxin that causes paralysis of the nervous system. So within just a few hours of being bitten, a patient will exhibit bizarre behavior followed by progressive paralysis of eye movements and respiration. The antivenom is available, but most hospitals do not stock it regularly, so you want to make sure that if you suspect this or know this was a type of snake, that you let them know so that they could get it as soon as possible. The emergency care is going to be the same as for a pit viper, and so we're going to get into what we can do with any type of sting here in just a moment. Now, scorpion stings. Scorpions are 8-legged arachnids with a venom gland and a stinger at the end of their tail. They are rare and live primarily in the southwestern United States and in deserts. With one exception, a scorpion sting is usually very painful but not dangerous. And this is the one very dangerous scorpion. Do not ask me how to say that because I have no idea, but very painful to say the least. Now, let me go back to this really quick. As far as with any type of snake bite, your biggest thing is to slow down the spread of the venom. And so different places are going to have different policies on what they want you to do. My best advice is to take a marker or a pen and draw a circle around where the bite is and the extent of the swelling. That way you can see how quickly is it swelling or how quickly is it becoming discolored and know how quickly the venom is beginning to spread. Again, you might elevate the area, you might splint the area, you might put an ice pack on the area, just depending on your local protocol. Those are some of the things that you can do to try to stop the spread. Now, tick bites, these are tiny insects that attach themselves directly to the skin, and they are found most often in brush, shrubs, trees, sand dunes, or on other animals. The bite is not painful, but it can spread infectious disease through its saliva. And you might see that question again, how is it spread? It is through the saliva. So the Rocky Mountain spotted fever occurs within 7 to 10 days after the bite, and this is one of the more serious things that can be spread by a tick, but also a major concern is Lyme disease. So the first symptoms are generally fever and flu-like symptoms, sometimes associated with bullseye rash that may spread to several parts of the body. Painful swelling of the joints can occur, and it may be confused with rheumatoid arthritis. Tick bites occur most commonly during the summer months, so if transport will be delayed, you can remove the tick with fine tweezers to grasp the head and pull it straight out of the skin. You might use a twisting motion to pull it out. Once the tick is removed, you want to clean the area with antiseptic and try to save the tick for identification. So you can put it like in a Ziploc bag. I wouldn't advise, putting it anywhere where it could get onto you, but you could put it into a Ziploc bag or something if you are taking it with you to the hospital. Now, looking at injuries from marine animals, these are responsible for more envenomations than any other marine animal. So those are your fire coral, Portuguese man-o'-war, sea wasps, sea nettles, true jellyfish, sea anemones, true coral, and soft coral. All right, so coral, obviously a major threat. And we do have some of these here in North Carolina, certainly off of our coast. So these could be a threat to us, or maybe you're traveling to an area where there are more beaches with more of these animals. So that's going to be it for environmental emergencies. If you have any questions, concerns, anything like that, you need me to explain something further, please let me know, and thank you guys.